Hello and welcome. I am Steve Clemens, editor-at-large of The Hill. Thank you for joining us for our program today, Innovation Forward, Technology and Diabetes Care, a virtual deep dive into what the future is going to look like for diabetes patients with the new tools, treatment, and technology that's coming online. I'd like to thank our sponsor, Eli Lilly, for their support of today's conversations. 1 in 10 Americans live with diabetes today, but we have also arrived at a new era in diabetes care. Innovative digital technologies mean blood glucose management and monitoring is becoming easier than ever. This means improved health outcomes and a greatly increased quality of life for more than the 34 million Americans who live with this chronic disease. Issues of access, affordability, and health system capacity are impediments that limit equitable access and optimal use of these innovations. Our show today is going to question if health policy and practice need to be rethought and to maximize the opportunity and value of these changing times. We're going to ask what barriers stand in the way of access to technological advances in diabetes care. How can policymakers reform systems to create more equitable access to these medical technologies? Before we get underway, though, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag TheHillDiabetes. We love it when you do that. Tweet up the storm. We're broadcasting live and we'll be taking your questions throughout our program today. And as with any live stream, you could experience occasional trouble with a video. Refreshing the page should, in most cases, fix the problem, I'm told. My first guest is a member of the Congressional Diabetes Caucus and the ranking member of the Energy and Commerce Health Subcommittee. Congressman Michael Burgess, great to see you again. Thanks for joining us. Let me just start this program today. Help me anchor where you think we are in the advancement of science and technology and what you see out there. You're the doctor in Congress, and combined with meeting the needs of patients, with this technology.
Oh, I think if you look over the horizon a little bit, you see a very bright future for people who are suffering from this illness, and the marriage of technology and medicine, and quite frankly, even artificial intelligence may pave an incredible way for people who are diabetic patients in the future. But in the immediate term, we've got some issues on access, and those issues generally center around cost access. So some of the things that I've been working on, in fact, a little over a year ago, we had a big bill in committee. I put an amendment for the committee to consider that for insulin purchases, a drug rebate that is paid by the manufacturer, that rebate should go directly to the patient at the time of purchase. My amendment was not successful in committee that day, but consequent to that, I am working on legislation with bipartisan legislation, would include a Democratic sponsor, and I would co-sponsor, that would provide just such an avenue. But the thing is, and what's always occurred to me when we have the hearings and we have stakeholders and we have patients in, you've got to do everything you can to make the access easy. And I can remember several years ago in talking about copays with then our former Speaker of the House, Newt Gingrich, and even the question came up, why even have copays? And former Speaker Gingrich said, you want to pay people to take their medicine. That's right. Particularly in this illness, the cost of not taking your medicine, the cost to the system are incredible. The cost to the patient, of course, the physical costs are significant. There is a cost savings to occur if you can, in fact, increase compliance. And that is, quite frankly, one of the areas where I've been working. So I do see a bright day in the future. The artificial pancreas has been slow to get through the FDA. Don't want to criticize the FDA, but at the same time, this is technology that needs to get in the hands of the patients. And Steve, you hit the nail on the head. Continuous glucose monitors have been a game changer for patients with diabetes, parents of patients with diabetes who worry about what the glucose level is throughout the day or night, can now have much easier access to that information. And that's just a godsend.
Congressman, why not criticize the FDA? I mean, I know the FDA is out there to be, a bulwark in protecting public health, but a lot of its rules, a lot of its standards are decades old. A lot of the processes that it has in place don't seem to be transparent. I have a lot of respect for many, many people at the FDA, and I understand that, but it doesn't seem to be a place. It gets very prickly when you get to questions of introspection and study and reform. And I'm just wondering if that isn't an area that we should look, have some stronger critiques of FDA performance.
Okay, don't get me started, Steve. Look, the FDA historically has been very risk averse, and that has been a concern of mine since starting in Congress. At the same time, that risk aversion is built on a platform of providing putting patient safety at the top of the charts. So you do have to be careful. You don't want to sacrifice speed for safety, but you are exactly right, Steve. There are plenty of times where I have gotten uncomfortable or anxious because of the length of time it seems to be taking the agency to get through with the regulatory process.
Fascinating. We should have a whole nother show about that one day, and I'm sure we could go on for a long time. Well, let me ask you on the diabetes front, when we kind of look at this broad accent of cost and access, and we know that diabetes hits different communities in America disproportionately, and it's like the case of COVID, where you've got communities of color that are wearing disproportionately. Maybe that's a function of cost and access. Maybe it's a function of other things. But as you were trying to get that rebate back, are there other developments on the cost side that you think are promising, that you think there would be bipartisan support of really getting in there to kind of broaden cost and access to get that out of the way when it comes to treating this chronic condition in the country?
Well, yes, the answer is yes. And certainly in the federal payer space, there are those advances. I think it was just a little early this year, perhaps in March, where the administration, through the Center for Medicare and Medicaid Services, announced that some Part D plans, some of the Medicare Advantage plans in Medicare could offer enhanced lower out-of-pocket costs for insulin. They kind of put a maximum on the copay at $35, allowed beneficiaries who take insulin to enroll in a plan. Participating in the model should save over $400 a year. So there are things that you can do in the federal payer space. Certainly in the area of the Federal Qualified Health Center, where they purchase their insulin through 340B programs. And this is another instance where I really feel strongly that the money ought to follow the patient. The money shouldn't follow the institution. The money shouldn't follow the insurance company. The money shouldn't follow the pharmaceutical company. The money should follow the patient. So in the 340B space, where savings are created by that 340B program, pass those savings directly on to the patient in the Federal Qualified Health Center. So that, coupled with a rebate refund, are some of the things that are at immediate disposal to be able to help patients with if cost is an access problem with their diabetes medications.
Michael, one of the things that's happened as a result of the COVID crisis is that we all used to talk a big game about going digital, but we really hadn't yet in the country. But we've seen a massive shift of the nation, grandparents with kids, Zoom calls for work, these kinds of sessions here, but also telehealth. And telehealth isn't just talking to your doctor. It's remote monitoring. It's all of that other data that flows from patients. And I guess my question is, what are your takes on the stability or fragility of that telehealth platform now? I hear that there's some concern that the reimbursements for that telehealth world may not be as sound as a lot of users of it think it should be.
Well, right now, telehealth is existing in the federal payer space. Telehealth is existing under waivers, and the waivers are in existence during the time of the public health emergency. So certainly Congress has work to do here to look at the results of what has happened in this explosive growth of telehealth. The benefit it has provided patients, the benefits provided physicians, and can we now legislate rather than do this as a waiver? Could this actually be written into legislative language so that our clinics, our doctors, our hospitals would have some certainty as to the payment structure? Right now, people are enjoying telehealth. Telehealth itself has undergone explosive growth during the time of the pandemic, but there are people who are asking questions. Can I actually plan long term around this, or are we going to go back to status quo as soon as you say the public health emergency is over? And I know about that anxiety because it is reflected to me in a number of conversations I have with patients. You also correctly mentioned the stability of the payment structure, and that is where, again, a lot of doctors and clinics have questions. And is there parity between what the federal payers are doing and what the commercial payers are doing? And that's certainly something that we in our committee should look at. But we should develop the language and the legislative vehicle by which the telehealth expansion is, in fact, now carried forward long beyond the realm of the public health emergency. I think the other aspect to look at, and one of the things that is also important in our committee, certainly in our committee's jurisdiction, is just the stability of the network and what is the broadband capacity. We, as a country, our broadband network underwent an enormous stress test starting March and April of last year. Telehealth, to be sure, distance learning, telework, working from home, all of those things were done over our networks. And for the most part, the networks withstood the challenge. I mean, you some stories of some troubles here or there, but in general, nationally, the network withstood the challenge. But it's also important for us to be sure that we have the proper infrastructure in place to handle what is now look, the pandemic will be gone one day. We will get past it. But is telehealth going to go back to status quo? I don't think so. Is distance learning going to go back to status quo? I don't think so. So the broadband network will have to be there to continue to provide the service that people now have come to expect.
Thank you for that. Let me ask you a question about where diabetes is in our priority roster of concerns as far as health. I think, one of the things I try to sort through when we're doing something like this is just set a context. And when I see that 10% of the American population has diabetes, 7 million are undiagnosed, I know you're in the Congressional Diabetes Caucus, but I'm also aware that something that big can just become tolerated at a certain point where the energy and enthusiasm to wipe it out or to roll it back may not be as robust. And I'm just wondering, and I'm just asking because I don't know the answer to it. Do you feel like it's getting the attention it needs? Do you feel like it's a neglected, taken for granted situation that people check off the boxes, but we're not doing as much as we should?
Well, on the continuum, I don't think there's any question that people are always going to say we're not doing as much as we should. At the same time, we are doing a lot. I don't think it's ever a good idea to get complacent with any disease, and certainly with this illness that can affect so many people in so many different ways, and then the consequent health problems as a consequence of having diabetes, as certainly you see that reflected in the kidney disease, end-stage renal disease, heart disease, the ophthalmologic problems that people have. All of these things they contribute to the entire cost burden of what diabetes represents. One of the things that has frustrated me over the years since I've been here is that when you talk about things and talk about, hey, we could do something differently here. Maybe that artificial pancreas is something that the federal government should be paying for. And then you take that to the Congressional Budget Office, they look at it and all they can see is a cost. They can't see what is going to be the benefit for someone having really, really great glucose control over the next 20 years. There is going to be a cost, there is going to be a benefit to that, which cannot be accounted for in a 10-year budget window. So one of the frustrations I've had is with Congressional Budget Office, we've got to account for everything within a 10-year budget window. When you get into preventive care, the cost is all going to be up front. The benefit is going to be in the future. So we need to have a more nimble way in our budgeting process to address that. I think there is no question you look at some major disease processes and you think, well, what would be the cost of doing nothing? And it would be substantial. So if there is a cost up front for a modification of that disease cycle, it's going to be a cost, but there will be a benefit down the road. We ought to be able to take that into account in our budgeting process.
Let me just ask you finally, Congressman, I know that you are someone who is saluted and proud of what the country seems to have done with Operation Warp Speed. A truly huge leap. I mean, if what we're hearing is true, and we have vaccine options at 95% efficacy that are safe, and there probably will be more down the road, one wonders with something that's affecting 10% of the population, people are going to begin asking, well, why not have an Operation Warp Speed around, the pancreas, which you just talked about, and to find other elements where we can, take smart minds, take money, create ventures that sort of move the needle faster. Would you be in favor of that kind of direction with dealing with diabetes?
Well, unquestionably, and that was the whole premise of a bill from a couple of years ago called Cures for the 21st Century, where we tried to examine the entire research and development phase, the cost of research and development, the time spent at the regulatory agency. How do we condense this? Are there aspects to consider, such as surrogate endpoints, where you don't have to wait the entire lifespan of someone to see whether or not this was a benefit? So Cures for the 21st Century was a major step in that direction. I think there'll be refinements of that Cures bill that will be coming forward. I think we also need to look at cost and access as part of that continuum as well. But I think the work is being done. Sometimes it does seem incredibly slow. You're right to reference Operation Warp Speed. Here is a real-time example. We were told when the genetic sequence was divulged in January of this year that it would be 18 months before a vaccine could be possible under the best of circumstances. And now as we sit here 9.5 months later, we've got not one but two vaccines that are 95% effective. That is unheard of. So it truly is a remarkable achievement for certainly the doctors and researchers in Operation Warp Speed. But you're right, we ought to see if that template could be applied to other areas of national urgency where health is concerned.
Well, Representative Michael Burgess, MD, thank you so much for joining us today. Really appreciate your perspectives on this important topic.
Good deal. Thank you, Steve.